Well, good afternoon, ladies and gentlemen, and a warm welcome from a magnificent Cape Town. As I look outside the window, all I see is the magnificence of this town, and of course, the magnificence of Steve. The mountain. So just remember that in a very short while, the 5th of October next month, we've got FIGO opening here right next door at the CTICC, and I'm looking forward to seeing as many as possible come through. There's still a few seats left, so if you are thinking about coming, we can accommodate you at the workshops and also at the actual Congress. The second thing is that Steve, I believe the Pelvic Floor Foundation is running an office hysteroscopy workshop.
No, it's the day after FIGO at our new Slate venue, and we still have some slots there as well. Chris, do we still have some available space on that workshop?
We do indeed.
Yeah, and Chris has already sent out the advert for the invitation for that, so you can certainly look at that. And it'll only be in the morning after FIGO, so if you are in town for FIGO, you can welcome to stay. It'll be at the new Slate Surgical Training Center.
That's wonderful.
Here in Cape Town. So
that's
yeah,
wonderful. To that. Steve, thanks very much. My name is Peter de Jong, and his name is Professor Steve Jeffrey. And his name, the third man, is Professor Ermos Nicolaou. Of course, he's a person that's been on here before. He needs no introduction, and he represents the BITS Health Consortium and the Morningside Mediclinic Center of Excellence. It's a wonderful topic that Professor Nicolaou has this afternoon, screening and triaging for adverse obstetric outcomes. So, ladies and gentlemen, I'd like to thank the Pelvic Floor Foundation for sponsoring this talk, and I'd like to especially thank Ermos Nicolaou for being with us this afternoon and presenting this talk, Screening and Triaging for Adverse Obstetric Outcomes. Thank you, Ermos.
Good afternoon, everyone, and a great thank you to you, Peter and Steve and Chris, for helping with organizing the presentation and the logistics. I do apologize for what happened last time, a couple of months ago. I could hear you and I could see you, but I don't know why I couldn't get through. But
we had load shedding. It was load shedding, Ermos. Load shedding.
Could be. As you know, Joburg is a bit of a third world country nowadays, but wait until we get a new mayor and then we'll sort it out. So enough politics. It's a long topic, so I would like to get going. I was going to speak initially about just the role of the NIPD, but I thought Down syndrome with an incidence of 1 per 1,000, 2 per 1,000 versus all the other things that can go wrong from the first trimester, where we have the opportunity to access, assess, and manage and be proactive. I thought it would make more sense to actually speak about a few more things than just chromosomal abnormalities and NIPD. In the era of AI, we are confronted with this situation where patients expect sometimes too much from us, and sometimes they leave disappointed because they don't have all the answers. And the AI is very much part of our lives nowadays and is getting better, and definitely there's a role for the AI. However, one has to be careful not to lose the skill and not to lose the human-to-human interaction. But we'll discuss that if you want to talk about it further later. So you all know that, and those of us who do obstetrics, the main areas where we trying to make a difference and improve the situation are either genetic defects, chromosomal abnormalities, obviously the commonest one, congenital structural abnormalities, brain, heart, kidneys, and so on. And of course, the issue of preterm deliveries that comes with the CP and all the medical legal implications we have in our country currently. So in this little pie chart here, you can see that nearly half of all the neonatal deaths and the severe morbidity and mortality come from the prematurity. And we define prematurity nowadays as anything less than 34 weeks, really. But again, it's a big chunk of problems, and we need to look at these numbers carefully and see if we can improve. So these are the 4 areas where I think we can make a difference as obstetricians and maternal fetal medicine specialists. But just to go through the basics for 2 seconds, when we come up with any screening test, we look at the numbers of kids that are born unaffected, kids that are born affected by condition, and we get the statisticians usually to help with where do we draw a line to make a sense in terms of screening test. Where is, say, the classic 5% false positive rate? Where would that line go? And in the 70s, the 5% false positive rate was at the age of 35. So they said, okay, if you're 35 and above in the 70s, and that was representing 5% of the population, you do an amniocentesis, you get the diagnosis of Down's or exclude Down syndrome, and everybody's happy. However, the reality, and that's basically what it looked like, there would be the vast majority of babies with Downs would be in that red area, and there would be a small minority, the so-called false positive rate or collateral damage, where some kids could be lost because of an amniocentesis that went wrong, but the baby ended up being actually chromosomally normal. The situation has changed, though. In the 70s, 5% of the population were above 35. In 2023, from my own data here, 40% of the population present with a pregnancy above the age of 35. And yes, you will have a slightly better detection rate, but still only about 50%. So now either you're going to do an amniocentesis on 40% of the population for a 50% detection rate, or you need to rethink the strategy of doing an amniocentesis for the advanced maternal age. So basically, what we are saying now, and I'm putting these 2 graphs together, 70s, 95% below the age of 35, 5% above the age of 35, 2025 or thereabout. So for us to achieve that 5% false positive rate and be statistically still acceptable without causing too much collateral damage, we'd have to move the age to 40. So the new 35 today is 40. And 40 would then still be considered advanced maternal age. You all know these pictures, the typical nasal bone presence and the normal kind of fluid collection under the skin behind the neck versus an increased nuchal translucency here and questionable presence of the nasal bone. And that's obviously how it looks like in an aborted fetus. So, and that's how the whole discussion started about the nuchal translucency screening and detection of Down syndrome and other chromosomal abnormalities. However, because now so many of us do first trimester screenings and we're pressurized with time and whatever, we sometimes don't follow the rules. For any screening program to work well, we need to be careful and follow the standards, because this is all standardized, so that we have reproducible results again and again and again. So the gestational age has to be 11 to 14 weeks or 45 to 84 millimeters, the crown to ram length. The section has to be mid-sagittal, and one easy way to know that you are mid-sagittal is by when you look at the nasal bone here and the zygomatic bone, there's no bone between. If you have a bone that connects the 2 structures here, then you are slightly oblique. The magnification has to be so that every time you move your calipers, that movement corresponds to 0.1 millimeters. The fetus has to be in a neutral position, as you see here. The fetus has to be away from the amnion. That's the amnion here. In other words, you don't measure the distance from the fetus to the amnion, which would be obviously incorrect. You use the maximum lucency, the biggest measurement you can get, and the calipers need to be placed on the inside of the lines. I will show you an example. Say this, that's the same picture. Patient is 30 years old, arrives to see you with a background risk for chromosomal abnormalities 1 in 600. But now it's Friday afternoon, and you've got a dinner arrangement or whatever, and you don't really feel like having a big drama and discuss for another half an hour the ins and outs. You put the calipers there, which is a smaller kind of lucency. The measurement of 1.5 millimeters would give a risk of 1 in 3,700, and the patient will live very happy. However, you have done a disservice because you may get into trouble for that. Because if that baby ends up being Down syndrome, and the lawyers and the judges and whoever expert wants to report on this, wants to look at the pictures, will say, but why didn't you measure there? And that measurement there of 2.9 millimeters, which would be the correct measurement, would give us a risk of 1 in 100, which is a high risk. In addition to the nuchal translucency, that has to be done again and again, very carefully, and thankfully there are audits that have to be done every year for those who perform nuchal translucency measurements, and they need to basically produce audits that are acceptable by the Fetal Medicine Foundation. Otherwise, they may not be relicensed. But in addition to the NT measurements, now we add biochemical markers. The common ones are the free beta HCG and the PAB-A, but we also there need to be asking the correct questions. I see patients who are heavy smokers, and I see in the printout from the lab, smoker, no, or IVF, no, race, unknown. And if you don't put that information in, don't even bother to do the biochemical markers, because obviously your results will be completely skewed. We know over the years, we learned what is the normal distribution of the HCG and the PAB-A in pregnancy. And we also learned over the years that in a Down syndrome, the HCG will be slightly higher than the normal distribution, and the PAB-A will be slightly lower than the normal distribution. And if you do that correctly, that program works well. On its own, the blood test results are not great. They come with a sensitivity of 60% or thereabout, call it even 70%, but not to the tune of 90, 95% that you want to in terms of having a screening program that actually is accurate. We also learned in the last years or so, 5 years, 10 years, that the biochemical markers vary within races and within racial classification within our own country. In other words, in South Africa, Black sub-Saharan African patients have different HCG and PAB-A and PLGF values to African ladies or Black ladies in the UK, who may be from Afro-Caribbean, from the Caribbean, genetically speaking, and therefore have different multiple of the medians. So we actually did a study, which I cannot present yet. It's has been accepted for publication in one of the British journals, and we'll hopefully soon we'll be able to share these results. But what we can tell you is that we have seen a statistically significant difference in the numbers between Black, Sub-Saharan Black, and South Asian patients versus their counterparts from the UK and the rest of the Western world. You may say to me, but isn't that a bit too time-consuming? How can you sit and do all these new translucency, follow these protocols to the letter to have these acceptable results? Well, we've done this study at Chris Hani Baragwanath Hospital, and that was some time ago already, where we have shown that the NT in a busy place like Baragwanath Hospital works well, and actually we save the government, the state, the hospital, a whole lot of money, because we did a lot less procedures for advanced maternal age, which, remember, was defined until not too long ago, anything above age 35. So out of 415 patients that we included in our study, 59 screened positive, 24 of those had a CVS, and actually out of those CVSs, we did 8 out of the total of 9 were found to have Down syndrome. So just by doing nucleotransfusion assessment and offering an early diagnostic test, we picked up the majority of babies with Down syndrome. Out of those who tested negative, 8 of them decided they wanted to have an invasive test because either of anxiety or family pressure or relatives with Down syndrome. None of those that were done showed abnormal results. We only had one baby that was missed, and that was in 2 patients that had a risk that was increased from their background risk, from their age-related risk, but that risk remained lower than the cutoff point that we put in our study to call it positive, so they fell through the detection. But that was one out of a whole lot of babies with Down syndrome, and a whole lot of procedures would have been done for AMA for the same result. So it worked well, and that is a study that is available to you if you want to read in the South African Journal of Medicine. And of course, fast forward a few years later, we came up with the cell-free DNA, which is actually the correct name to use, cell-free DNA, as opposed to the NIPD, which implies non-invasive prenatal test. It is invasive to the mother. We still stick a needle in her arm and draw blood. However, we can use either term. Everybody will understand what you're talking about. So the story here is that cell-free DNA, mainly from the placenta through the process of apoptosis, ends up in the maternal circulation. And from there, we can harvest those cells, that DNA rather, and analyze it, and now make prediction with a very high degree of accuracy whether the baby has Down syndrome or not. The strength of the NIPD is actually the negative predictive value of the test. We believe the statement when it says no Down syndrome. When it says positive for Down syndrome, we need to test it further. That is the current recommendation. You do an invasive test, either a CVS or an amniocentesis. So where does the cell-free DNA would then fall? Because everybody now wants to do cell-free DNAs. They are expensive. The medical aids fight. They don't want to pay. So where we kind of envisage the NIPD to be performing its best is in that intermediate risk group. In other words, if we look at risk cutoffs for Down syndrome of 1 in 300 or higher, that would include 80% of babies with Down syndrome, and that would be only a small minority of the population, about 2%. You give them an invasive test, and you pick up the vast majority of babies with Down syndrome. Those who test low risk, and that is less than 1 in 1,000, that will be 88% of the population, and will include about 5% of babies with Down syndrome in there. And then there is the so-called intermediate risk group, which is the 1 in 300 to 1 in 1,000, and that would be an acceptable 10% of the population with an acceptable 15% babies with Down syndrome, and the cell-free DNA should be actually done for that particular group. The medical aids have agreed that this is a good way to go about it, although nobody will stop a patient to request an NIPD when she is in the high-risk group. The medical aid will not accept to pay if the risk is lower than 1,000. But then again, life is not only about medical aids. Patients need to make their own choices. So those who test positive with the cell-free DNA for Down syndrome then get sent to this group here, where they will have a confirmation test. And those who test negative, they go to the low-risk group and have another scan at 22 weeks. So as it is currently, and let's just put the last column as well. So screening by maternal age on its own, no longer advisable. We have too many ladies above 35 to practice that alone. Nucleotransfusion on its own works well with a detection rate of about 80%. But nowadays, with the inclusion of the biochemical markers, you achieve a detection rate of 90%, and then you have another chance to do the so-called soft marker scan at 20 weeks, and you have an overall detection rate up to 98%. Or you can offer everybody, the entire population, a cell-free DNA test where you will have nearly no Down syndrome children, but it will be quite an expensive exercise and not recommended. So the current state of affairs with the cell-free DNA is that we offer some of the common chromosomal abnormalities testing like Down syndrome, Edwards syndrome, Patau syndrome, but we're throwing in a few so-called microdeletions. And I don't think that we need to worry too much about all of these things here unless we have evidence, either from the scan or from the family history, that you may need to investigate for these things. But I am going to stop for 1 second here at the 22q microdeletion, the Dye-George syndrome, as they call it, because as you see, the Dye-George syndrome, it's higher than all the other conditions and only second to Down syndrome. So it is a high risk or higher risk than all the other chromosomal abnormalities and microdeletions, particularly if you look at the lower, younger population groups, say 25, 28 or younger, actually there's a higher chance for the Dye-George to be present than Down syndrome. I will give you a case study quickly, which I was involved a couple of years back. So a patient who was 33 years old had an IVF, and at the IVF center, they did a NIPD. The NIPD came back as normal, and everybody was happy. Good fetal fraction, so a reasonable, good quality test. She came to see us at 20 weeks. And, you know, routine scan, we didn't really worry much about it, but look at that heart. All right? So there was what we call so that's an AVSD or conotruncal abnormalities, and I want to continue. So with a bit more magnification and color Dopplers, we could see that this could be either a tetralogy of Fallot or common arterial trunk. And actually, this particular case was a common arterial trunk, and I don't want to complicate things here, but you can see the big opening here. You see that big vessel coming from nearly astride the two ventricles, and suspicion, possibly Dye-George, because when you have conotruncal abnormalities, the commonest abnormality would be either chromosomal, like Down syndrome, or Dye-George. Anyway, we phoned the lab and asked them if they have still some of that sample that was sent earlier for the basic NIPD. And they said, yes, they did. They look at the microdeletion 22q Dye-George and actually was present. But this was nearly missed because the NIPD didn't pick it up. And obviously, unless you go to an expert to look at these things, it may actually be missed. And Dye-George is a terrible abnormality. It comes with mental retardation, lots of behavior issues, and of course, lots of cardiac abnormalities. In addition, when you have an increased nuchal translucency, you want to look at more things than just Down syndrome. You want to do the second most common reason why a baby has an increased nuchal is cardiac abnormalities. If the nuchal translucency is higher than 5 millimeters, 7, 8 millimeters, the risk of having a cardiac abnormality increases by 200 times. Yes, there's an overlap between cardiac abnormalities and chromosomal abnormalities because the one can produce the other. But still, there will be some babies that are chromosomally normal and have other issues that need to be detected somehow. And if the 16-week scan doesn't produce any results because it's simply too early, we continue and we have another good look at 22 weeks. Just by having increased nuchal translucency and nothing else, that is a poor prognostic factor, and nearly 50% of those babies may actually end up not surviving until the end of the pregnancy. And of course, needless to say, as I already mentioned at the beginning of my talk, there is so much more that can go wrong with a baby than just Down syndrome. You can developing anencephaly, horoprosencephaly, a spina bifida, a large exomphalos, a megacystis, probably from posterior urethral valves. So all these things, if we were to do only NIPD, and a lot of patients think, done the NIPD, pregnancy sorted, that is so wrong, because we've got to have a good look at everything else. Don't forget twins. Twins, by default, carry a high risk. So as you can see, the comparison between monochorionic and dichorionic twins, less than 24 weeks, much higher risk of fetal loss. And even after 24 weeks, higher. This is the breakdown here, where you can see risk of miscarriage, risk of perinatal death, fetal growth restriction, preterm delivery. So twin pregnancies are high risk, no matter what. Unfortunately, our IVF colleagues, now they do it a bit less, but until recently, they would not hesitate to put 2 or 3 babies in, sometimes even 4. And of course, that was a recipe for disaster. The NIPD can help you there as well, particularly for the common chromosomal abnormalities, Down syndrome, Edwards syndrome, Patau syndrome. The rest becomes a bit more complicated. The George and all of that. If it's a twin pregnancy, they may not be able to give you a conclusive result. And sometimes if you have a twin pregnancy where the one baby has died, and possible cause, 50% of them could be chromosomal abnormalities, you may have a normal fetus here, but you do the NIPD and you may get an abnormal result because of these little dead baby here. These are technicalities that one has to be aware of and think about the next step before you do any test. I'm going to move to the next topic, which is the screening for preterm delivery. As I said to you earlier, nowadays we define preterm delivery less than 34 weeks. Nobody cares after 34 weeks. The pediatricians and the neonatal ICUs are capable of looking after babies after 34 weeks. I'm not suggesting that we now need to deliver babies after 34 weeks just for the sake of it. No, I am saying for those babies, if we can get them to 34 weeks, they can do better than if they were to be delivered before 34 weeks. So 2/3 of those babies that are born prematurely are spontaneously delivered because of premature rupture of membranes, the inability of the cervix to keep the babies in. And 1/3 are those that we feel the placenta is compromised. We have preeclampsia, antiphospholipid syndrome, and so on. And these babies would be better off outside than inside the uterus. Out of those who deliver spontaneously, 15% of the patients will present with a previous history of preterm delivery or recurrent miscarriage, but 85% actually will not present with a previous history. So that was precisely the mistake we all did when we started looking at the performance of these screenings for preterm delivery, say the cervix and so on, because we were concentrating on the small minority of patients that presented with a previous history. And those who did not have a previous history, we didn't worry about them, which was wrong, because since we started looking at universal, and I'm going to move away from that, universal screening for cervical length, prognosis improved, the management techniques improved, and we have better outcomes. These are data from our own center at Chris Hani Baragwanath Hospital, where we looked at about 1,600 patients, and we found that 4% of our patients had a cervix that measured less than 15 millimeters, 7% measured between 15 and 25, the intermediate length cervix, and the majority, of course, measured above 25 millimeters, which would be defined as normal. Did it matter? Yes, because when we look at the results and progressively watch them, how they did, those who had short cervixes, only about 50% managed to go beyond 37 weeks, and all the rest delivered before 37 weeks. If we look at those who had an intermediate length cervix, the picture was a bit better. 77% went above 37 weeks, and the rest before 37 weeks. And those who had normal cervixes above 25 millimeters, the majority, 90% of them, went beyond 37 weeks. So just by looking at the cervix alone, without any intervention, you can see that the size, the length of the cervix matters. And therefore, it's a very strong case to be made that we should be looking at the cervix from 12 weeks routinely, because we may actually be able to make a difference. So what can we do about short cervixes? That was the study that we did as part of that big study that Chris Hani-Baragwan was involved in. These are the data I just showed you. It was published in the Lancet in 2004, where initially those who had a short cervix were randomized to either have a cerclage or not. And although there was a trend, you can see a clear trend, the cerclage was beneficial, did not achieve statistical significance. And therefore, although there's a clash, we all feel it was unfairly kind of shown that it wasn't really working because we really think it works. Statistically, did not achieve that significance. What we have found since is that progesterone in the late first and early second trimester made a big difference, caused a reduction of more than 45% in the cohort that received progesterone versus those who received placebo. And that was a study that looked at every patient that came in, had a routine check of the cervix, despite of first or previous pregnancies or not, with a history of preterm delivery, and the results look pretty promising. So much so that now progesterone became, standard protocol. Everybody gives progesterone to those patients who we think are at high risk to have a premature delivery. There were ifs and buts, and some study, the Optimum study by Diana Bianchi, showed that maybe it wasn't as great as after all, but there were some errors in the study. The inclusion criteria, exclusion criteria were not as clear-cut. And when they decluttered the study, like all the other studies, showed that there was a benefit in giving progesterone to delay or avoid, up to a certain extent, preterm delivery. And that was a meta-analysis done by Roberto Romero, which was published in the White Journal in 2016. Initially, there was this question mark about, do we do the same for twins? Do we try other things? And then there was the Arabian pessary that you put on the cervix, and we hope that pessary will keep the cervix closed. Unfortunately, it didn't work, didn't really make any difference. But by gaining numbers, and various studies starting to show that, and again, Roberto Romero, a year later in the White Journal, published the second meta-analysis where he showed that progesterone, even in multiple pregnancies, in twin pregnancies, works, was beneficial versus those who did not get progesterone. How do you administer the progesterone? The truth is that the initial studies by Roberto Romero were done with intramuscular progesterone. The FMF group in London with Kypros Nicolaou were favoring the vaginal pessaries. Nowadays, we don't really do injections unless patient, for some reason, requires the injections. Otherwise, either oral or vaginal. The studies are still talking about vaginal progesterone, but I think with increasing numbers of oral progesterone, we may actually get pretty significant results there too. And then the last area, and I'm looking at the time to make sure that we have some time to have a discussion, the ischemic placenta disease and preeclampsia. Again, these are things that from the first trimester can be picked up, and we can make a difference, sometimes very inexpensive intervention like low-dose aspirin. Whereas if we miss that boat and we start looking at preeclampsia in the second trimester, it's too late. So we now separate the term preeclampsia, which when we were students in young registers, everything was the same. Now we know that we have a separate entity, the early onset preeclampsia, which is the one that we classically recognize with the abnormal placentation, the early onset IUGR, the blood pressure goes through the roof, and these babies rarely get over a kilogram fetal weight. And the late onset preeclampsia, which actually implies more placenta aging, and the theory is, and actually I think it's pretty recognized now, that if you allow any pregnancy to continue to 40, 41, 42, 43 weeks even, every woman would develop preeclampsia, just simply because of the placenta aging. So late onset preeclampsia, tricky to diagnose because the baby may still be within the normal ranges, but if you prospectively look at the baby's weight, how it crosses the percentiles, even if it's still within the normal ranges, above the 10th percentile, that alone may suggest late onset preeclampsia. And why is it significant? Because studies have shown that these babies also start running low on reserves, and they may actually benefit from delivering them at 37 weeks by cesarean section versus going to 39, 40 weeks and allowing labor to set in. It's a tricky condition because it is multifactorial, not one size fits all. It could be fetal reasons, could be maternal reasons, could be placental reasons, or could be external factors. All of these things can actually cause the same condition from a different starting point. And that makes it very difficult to diagnose or even approach diagnostically. So that's why even more so to be vigilant and do assessments from 12 weeks when you do your new cut translucency and you spend a lot of money to do the NIPD and whatever. This is completely inexpensive because all it is just with your ultrasound probe, when you finish with the new cut, look at the blood flows, the cervix, look at the uterine arteries, and you will make such a difference. So here, the common culprits that will increase any patient's risk for ischemic placenta disease, history of hypertension, abnormal high resistance in the uterine arteries, and of course, presence of antiphospholipid syndrome. Some of the green highlighted areas like mild smoker, previous parity that went well, young age, work to the patient's benefit. And other things like previous history of preeclampsia, increased BMI, family history, race, these may increase the risk of preeclampsia. So that's something that you would be able to get from your history when you see your patient for the first time. Pretty straightforward, I think, to ask these questions. And you will then be able to place your patient into high risk or low risk group. The trick is to be able to identify these things before you get into that placental insufficiency, and of course, the baby starting to feel the pressure, doesn't receive enough nutrients. You have a baby that is growth restricted, and it's too late to do anything because you have missed the boat. Why is it important to do that in the first trimester? Because from the first trimester, you can actually see the difference in the blood flows in the uterine arteries between normal low pressure system versus a high resistance, high pressure system. As you all know, in pregnancy, with the pregnancy hormones, the vessels dilate, and I will show you a slide just now. They become low pressure systems, allow much more flow to go through, preferential flow to the uterus and to the placenta. Whereas if they fail to do that, then you have a problem. By looking at the uterine arteries, it is quite an easy thing to learn because the uterine arteries are always where they should be, unless there's some rare congenital abnormality, and you should be able to access them and get this kind of flows. Part of the History nowadays should include, are there any systemic conditions? Is there any history of chronic hypertension, chronic cardiac disease, any history of diabetes? Is the patient obese? Studies have shown that metformin, and a lot of infertility centers actually use metformin routinely, can reduce the risk of preeclampsia in patients with a metabolic syndrome up to 50%. And of course, the thrombophilias, particularly the acquired thrombophilias, the SLE, antiphospholipid syndrome, that anticoagulation seems to be very, very beneficial. Factor V laden, antithrombin deficiency, CNS deficiency are also important, but less significant than the antiphospholipid syndrome. So what happens with the failure of the vasculature to become a low pressure system and remains a high pressure system? We have come a long way to recognize how these things work. Problem is, we cannot come up with an idea how to fix it before it becomes a problem, but we can now more and more accurately recognize the condition. So we have the placenta growth factor, and we have the soluble fluid and the fluid. The soluble fluid is the one that is floating in the vasculature, attaches itself into the vascular endothelial growth factor, these things here, and allows less placenta growth factor to attach itself onto the receptors that are waiting for them here. And if you have too many S fluids floating around, then obviously you have less modulation of the vasculature. We have what we call a dysfunctional endothelium, and this patient may be at a high risk to develop preeclampsia. And of course, nowadays we talk about the S fluid versus placenta growth factor, and we look at ratios. This has not been verified yet in our country, although there are studies ongoing where we actually see that it would work in our population the same way as it does overseas. The PAP-A, which was traditionally used for the screening of Down syndrome, we have shown beyond any doubt, these are our own data, but also studies from the UK have shown the same thing. The lower the PAP-A, and when I say lower, we're talking about MOMs, multiple of the median. These values, when they come to you from the lab, they will come as a raw value, and next it will be 0.5, 0.4 MOM. And that is the number we're looking at. That multiple of the median, less than 0.5, 0.4, increases the risk of hypertension in pregnancy, risk of abruption, and a poor outcome. So now you do a first trimester screening, you look at the nuchal translucency, you look at the uterine artery, you look at the cervix, and you do the first trimester biochemical markers. And that's all you need. Yes, you may only see one patient per day, but at least that patient will be seen well. What happens to those who screen positive for preeclampsia in the first trimester? The famous ASPRE trial that was published by Kypros Nicolaou in the NEJM showed that those patients who screen positive, and they define high risk or screen positive, the ones who had a risk of higher than 1 in 100, they gave them low dose aspirin, and they define as low dose aspirin 150 milligrams per day. In South Africa, a lot of us use Ecotrin, which is 2 tablets, 2 Ecotrins, same thing. And by doing so, you actually achieve fantastic results, particularly for the early onset, the severe early onset preeclampsia, more than 80% reduction. And please don't ask me, what about paracetamol and Donald Trump's association with autistic behavior? We're talking about...
Okay, we won't ask you. We won't ask you. We'll say nothing.
You can, but I will tell you to keep quiet. So what happens if we start the aspirin later than first trimester? Studies have shown that if we start aspirin after 16 weeks, actually we increase the risk of placenta abruption. So if you're going to do this thing, you've got to screen in the first trimester and prescribe low-dose aspirin in the first trimester. And then 2 things about antiphospholipid syndrome. I know the diagnosis is very tricky. Biochemical markers can be all over the place. And of course, the guidelines say you've got to test, if positive, retest 3 months later, 12 weeks later, and only then the patient is classified as antiphospholipid syndrome. I think there's a problem with that because in pregnancy, you don't have the luxury of waiting for 3 months. And sometimes pregnancy can actually induce this kind of situation. So you may say, but why don't we test when the patient is not pregnant, where we're not under pressure, because it may be a different picture altogether. So you may want to practice what I would recommend, the clinical criteria, which is 1 or more unexplained deaths of a morphologically normal fetus at or beyond the 10th week of gestation, or if you have the luxury to have this history, 1 or more preterm births of a morphologically normal fetus before 34 weeks of gestation because of eclampsia or preeclampsia or other recognized features of placental insufficiency, or, and that's quite important, 3 or more first trimester miscarriages before or at around 10 weeks with the parents being tested and chromosomally found to be normal. So if you do this kind of clinical criteria and the patient ticks the boxes for antiphospholipid syndrome, the treatment would be a low molecular weight heparin together with low dose aspirin. And by doing so, you actually achieve fantastic results. There are some experimental work on chloroquine, statins, and so on that seem to be promising, but they have not been verified yet. And we don't know also much about their safety. But for now, low molecular weight heparin, Clexane, and low dose aspirin seem to be the standard of care. And we also recognize that these babies, as they grow older, how they follow that pattern of a reduction of growth, then eventually become growth restricted, amniotic fluid gets reduced, and then eventually, just before the baby dies, you may pick up abnormal CTG changes. And that's why we need to be proactive and try and identify these things before they become that bad. Just one example of what I'm talking about bad. If you see umbilical cord flows that look like that, reverse endostolic flow or absent endostolic flow, reverse endostolic flow implies 70% of the placenta is not functioning. So that's terrible. If you can afford to deliver the baby because the baby is viable, consider that. I'm going to leave that for now. I think that's so getting towards the end. That's my second last slide. So important to do these things from the first trimester: history, blood pressure measurements, evaluation of the uterine arteries, do the biochemistry if it's available, and consider aspirin to those who screen positive. All right. And then one word about sugar. Don't forget diabetes, very underdiagnosed in our country, where if a patient ticks the boxes here of the criteria for testing, such as previous gestational diabetes, unexplained stillbirth, big babies, family history, obesity, this patient may benefit from having the oral glucose tolerance test. And why is it important? Because patients who are diabetic, even if they have gestational diabetes only, they also need to be put on a low dose aspirin because diabetes is a vasculopathy. That's what it is. So you've got to address them the same way. And this is my very last slide. Nowadays, with the NIPD offering us rhesus status of the fetus, not to everybody, those who test, those mothers who are rhesus negative and have a father of the baby who is rhesus positive, the NIPD can be done, included in the price, no extra charge, and will tell you the RH status of the fetus. Don't forget to do this. Do you know how many patients come to us with sky-high antibodies, and we don't even know the blood group of the father or whether the father was ever tested? You may argue, but do we know who is the father? In the UK, they said more than 10% of the fathers were not the fathers. Nevertheless, doesn't harm to get these questions answered, and because at the end of the day, if you know what's going on and you identify these things from quite early, either you refer the patient to a center where they can do these things prospectively, or if the father is also rhesus negative, then at least you relax. And I gave a talk at the Congress in East London a couple of months ago. What we are doing now, we are conservatively managing patients with high antibody titers with hyperimmunoglobulins from quite early, from about 18 weeks, with great results. We achieved to suppress the rhesus antibodies, and sometimes we manage to get away without doing any blood transfusions, or we delay the need of blood transfusions until much later in the pregnancy. I thank you for your attention, and I'm going to minimize this if I can. Yeah.
Thank you so much, Ermos.
My pleasure.
We've got, it's been a wonderful talk, wonderful Cook's tour. I was at the Royal College meeting in July in London, and there was Kypros Nicolaou saying for 30 years, we've known about nuchal translucency, cervical lengths, PAP-A, history, uterine artery flow, and yet 30 years later, we're still not doing that. At least in the British Isles, they aren't, in the UK, and that's meant to be a first world country, and they're no further than they were 30 years ago. Do you think things are improving in our country?
Look, so not many people are going through the process of accreditation. But in our country, being our country, we have the labs that give us what we were meant to be doing ourselves, the biochemical markers. They give us risks of chromosomal abnormalities. They use a different software. That software is not completely correct, but at least gives you a pretty good idea of whether the baby is high risk for Down syndrome. So I think we are better off than the UK and some of the other countries where they are so regulated that would prohibit labs to give you these kind of things. So we are probably better off.
Yeah, that's what I thought. So, Steve?
I just want to ask, thanks so much. It's so, for non-obstetrician, it's actually very interesting to see what has progressed, but interesting what hasn't progressed over the years. But do you think as the NIPT gets more accessible and cheaper, it might replace some of this stuff? Because, I mean, I think we're at that point where we might, when it comes to economies of scale and as things start to scale, we might have access to much cheaper NIPT. Do you think that could potentially minimize the need for some of these more extensive training in the nuchals and also in the lab tests?
Will NIPT overtake nuchal translucency?
Look, to a certain extent, it has already. I've got a series of lectures which are, because I'm doing every week lectures, and from my own data, I can say the vast majority of patients we see nowadays, they don't even wait for us to say, oh, you're high risk, go into the NIPT. They come with the NIPT already. So it became almost standard of care. Clearly, there's a price attached to it. And as Steve, you said, would it eventually become cheaper? I don't see why not. The technology is already in the country. If the labs reduce the price, they will be able to get a lot more patients, more numbers, and therefore they will still recover their expenses.
What's the price? About 6,000-ish?
6,000 is your standard, for the standard NIPD.
Okay, thanks. Ermos, you spoke very highly. Sorry, yeah?
Yeah, no, I wanted to say, for us to get this in the government sector, guys, we need to have the political will. And currently, we don't have that. We haven't achieved that by government, and therefore, in the government sector, unfortunately, not in the foreseeable future.
Yeah, it's interesting. Some things go well in the government. For example, the Tdap's gone well, and the Gardasil stroke Cervarix has gone well, but some things we're suckling.
Yeah.
You spoke very highly, Ermos, of aspirin given before 16 weeks. In fact, you spoke so highly that I think that everybody should have it. What is your take on that?
Not everybody. The American school of thought feel very kind of liberal about giving aspirin to just about everybody, even if you're slightly overweight. I think they're more in-depth assessment as the Fetal Medicine Foundation has proposed, where you look at the uterine arteries and you look at the overall risk of the patient, and only those who screen positive get given aspirin, you will achieve better results because your treatment would not be diluted in the masses, in the millions of people. And also the evidence has shown if you don't need it, it's not going to make any difference. So I think doing a targeted screening makes sense.
Okay.
But if you're in doubt and you feel, I'm not sure, I'm quite worried, this patient is a bit obese, blood pressure is kind of sitting on the fence, by all means, it's completely harmless. As far as I know there are people that say, no, it's not completely harmless. In my opinion, it is harmless. Give it, because on balance, it's better to give it than not to give it.
I get it, and I agree. On that score, if a woman has, we send a lot of the placentas away to Lancet for analysis histologically after deliveries in IUGR. Say they come back and they say there's placental vascular abnormalities of a placenta. What do we do in the next pregnancy? Do we give the aspirin, or do we have to start again and rescreen everybody, Ermos?
Yeah, look, previous pregnancy or preeclampsia, history of preeclampsia, and so on, obviously would be one of the risk factors that you would consider. But the pathology of the placenta, unless it's done by specialist placentologists, like, for example, Professor Colleen Wright, who I'm sure you know, unless you have a reputable pathologist looking at the placentas, the reports can sometimes be, okay, there is that vasculitis or whatever, which you get just about everywhere. And what does it mean?
I said every time. And Ermos, we're running out of time. Just say what you said about smoking. Did I understand you to say if you smoke
one a day?
Look, that's what you do, and Steve. So it's
saves lives.
Smoking saves lives. Are you saying that one a day of a cigarette is a good idea? Is that what you said?
So no, that's not what I said. What I said is, if you have a patient who is a smoker but smokes 1 or 2, call it 3 a day, that patient will probably be better off without stopping that 1, 2, or 3 cigarettes a day. If a patient is a smoker, don't get you to start. Rather put you on aspirin. If it's a choice between aspirin or smoking, rather get the aspirin.
Okay. How many do you smoke a day, Ermos?
None. I used to be a heavy smoker about 30 years ago.
Okay.
I stopped completely. And I wasn't even pregnant. There you are.
But you are now. Ermos, we've got 1 more minute. I'm going to ask Steve to thank you very much. It's been a wonderful talk, and we've learned a lot. And I'm sure it's changed our practice, particularly what you've mentioned. So, Steve?
Yeah, absolutely. Thanks so much, Ermos. I think we can't hear enough about this stuff. I mean, it's changing. It's becoming much more accessible to people. I think one thing though is, do you think we're counseling our patients enough? With all this access to this treatment, you get an abnormal result all of a sudden. I think that, as you said, you're rushing off to your dinner and suddenly, I think that's the reality of your days. How do you think you would say to people how do you counsel your patients about the potential abnormal result? You get numerous normal patients, and suddenly get that one that's thrown with this abnormality. How would you suggest we preempt that problem?
So look, I think from the moment you start doing this kind of screening, you've got to provide the time, and you have to provide the knowledge as part of your counseling, because you cannot tell a patient you are high risk and then just left her hanging, or at least hanging for the weekend. So you've got to be able to sit down and explain the findings. Do you know how many patients go and do the NIPD and they don't even know that they've done it? They come here and they say, I've done that blood test, I don't know what it is. And you say, did you pay 6,000? Yes, I did. Well, that's the NIPD. So counseling is a problem in our country. We need to improve on our counseling. And also when we do, we do medical legal cases, colleagues of ours, friends of ours, get into trouble because they did a scan and the scan was reported as normal, and then there's some terrible abnormality, And they say, well, but I'm not trained to do these things. But then why do you say everything was normal? If you haven't been trained, then disclose that. Say, look, I'm going to do a limited scan. I'm going to check gestational age. It's only one baby. I'll do the new contrast. But more than that, if you want more detail, then you need to go and have a detailed assessment. So you cover yourself.
Got it.
Yeah, it's absolutely important.
Erwin Gertner, just in the dying minute of this, he thanks you very much. He just reminds everybody that Tuesday afternoon at 5 o'clock, you have a wonderful webinar. People go, and we would love to have you again here, Ermos, and talk about some of those subjects. The final question is from Lionel. What does that say, Steve?
Well, it's the question is, without the privilege of 3D first trimester screening, what basic chromosomal blood screening is valid? 3D.
Can you explain that?
Maybe triple, maybe triple test first trimester. Anyway, yeah.
I'm not sure if I get the question.
We don't really understand it either. So yeah. So should we?
I will
maybe you
ask,
can send that separately, and we can.
Yeah,
we can
I will ask Leon to, ask Leon to forward that email to
thanks
you,
very much.
and you could answer directly. So Ermos,
Absolutely, with pleasure.
Thanks very much, and of course it was wonderful to have you, Ermos. Erwin was saying that you might be able to share a link to that webinar that you do at 5 o'clock on a Tuesday. So maybe we can. Are you happy for people to? Where can they find it if they want to get access to your personal Tuesday night 5 o'clock webinar? Or is that only for fetal medicine?
No, it's for, we have a similar forum to you guys. We have people from all over the country. I'll send you guys the link, and then you can share it with your people there.
Wonderful. Okay. Yeah, I mean, I think it'd be lovely to have a little bit more of this and elaborate on this more. So thanks so much. And again, thank you for coming. Have we got a webinar next week, Pete?
You certainly do. Just quickly like to thank Chris. Chris, do you have the title for next Thursday? Is Crystal with us? He's drinking.
No, I'm right here. It's a hysterectomy update by Dr. Suleiman Halen.
Okay, that's good.
Hysteroscopy update, did you say?
Yes. Yes. No, it's all right.
And obviously, yeah. Sorry, Suleiman. Sorry. Chris.
Sponsored by Novo Nordisk as well.
Okay, of course, thanks to them. Wonderful. And then obviously the next week there won't be one because it's
FIGO,
some small conference at the CTRCC next door. And but thanks so much, Pete.
Thanks so much, Steve. Thanks, Ermos. It's wonderful having you again. And of course, for me not to thank Steve for the use of your minibar, which needs some replenishment. So see you all next week over here, same time, same place. Thanks again, Ermos. All the very best.
Cheers. Bye-bye. Thank you, guys. Thank you.
Safe home.